Thank you, Mr. Chairman. Ladies and gentlemen, I'm so honored and delighted to be here today among you in this outstanding scientific meeting and in the beautiful country of Egypt. Let me first thank the organizing committee for allowing me this honor and for inviting me to talk about a very, very delicate topic for us nephrologists in our daily practice. It's an update about hyperuricemia in CKD patients. As you see, this topic is delicate because it raises many questions for us practitioners. First, about the link between hyperuricemia and chronic kidney disease. Second, about the treatment. Should we treat or not these patients, especially those who present with asymptomatic hyperuricemia? As we all know, that it's not easy to manage uric acid lowering agents. And third, if yes, if we should treat these patients, what is the evidence and how strong is the evidence? And will this impact the progression of the kidney disease? That means, are we going to improve the worsening of the kidney disease or to prevent the onset of kidney impairment? So these are the questions we're going to see during this talk based on the latest, the most recent and current data. So how can I? So as you know, in humans, uric acid is the final compound of purine's catabolism. 2/3 of uric acid are produced endogenously, primarily in the liver, the intestines, and the muscle. And 1/3 is derived from dietary sources, alcohol, fructose, some certain meats, purine-rich foods, seafoods, for example. So these products are going to be degraded into nucleotides, then purine bases, that will be transformed into hypoxanthine, and then uric acid because of the action of a very special enzyme that is xanthine oxidase. In other mammals, there is a special enzyme too, it's a very different enzyme, the uricase, that will degrade uric acid to a soluble product, the allantoin, that will be easily eliminated in the urine. In us humans, this uricase has been lost throughout the evolution for some misknown reasons, but luckily we can produce it in the labs. So the kidney plays an important role in uric acid excretion and reabsorption, as it eliminates 60% of the total excreted uric acid. Uric acid exists in the plasma in the form of sodium urate that will be freely filtered by the glomerulus, then reabsorbed by coordination of transporters that are dependent of the sodium reabsorption, mainly in the proximal tubule. I'm going to focus and to cite only the key transporters that are involved in these actions. For the reabsorption of uric acid, there is the URAT1 on the apical membrane and GLUT9 in both the apical and the basolateral membrane. There are two other main or key transporters that are involved in the secretion process, facilitated by a facilitated mechanism. It's the NPT1 and 4 and the OAT1, 2, 3 on the basolateral membrane. And this brings us to define hyperuricemia. Hyperuricemia is an elevated serum uric acid that refers to an overproduction and or insufficient element excretion of uric acid. The normal range value does not make consensus among practitioners, but usually the range of 35 to 70 milligram per liter is often used by researchers with a threshold of a level superior to 70 or to 60 milligram, 70 in men and 60 milligram in women. What is interesting about hyperuricemia currently is that there are many studies that do consider it as an independent risk factor for hypertension, diabetes, cardiovascular disease, and kidney disease. Let's first examine, or rather explore, the link between uric acid and CKD based on experimental data. As you know, uric acid in the plasma does have an antioxidant effect, but once uric acid enters the cells, it displays an oxidant effect, the opposite, and triggers inflammation via stimulating levels of MCP1, NF-kappa B, and so on. There is another study that shows in rats, always in experimental models, that the uric acid does induce afferent arteriole thickening and podocyte injury, which causes, of course, albuminuria. And there is a extensive body of evidence that shows that uric acid does cause RAS and COX-2 systems activation, endothelial mesenchymal transition, and endothelial dysfunction and fibrosis that all lead to kidney fibrosis, of course, and loss of kidney function, of course, CKD. So clearly, there is a vicious circle between the impaired renal function and the accumulation of serum uric acid. Impaired renal function leads to the accumulation, and the accumulation of uric acid leads to kidney impairment. That's what we've seen so far in experimental models. What about patients? So there is also a substantial clinical data that shows a connection between high serum levels, uric acid levels, and CKD. As the prevalence of CKD in adults with hyperuricemia is something like 2 to 5 times superior to that in adults without hyperuricemia. Let's see together this meta-analysis, very interesting meta-analysis, published in 2014 that has included both prospective and retrospective studies with a mean follow-up of 4 years. It shows clearly that high uric acid may not be merely a consequence, but rather a novel risk factor in CKD onset and progression, both onset and progression. In this Japanese renal biopsy study, in 167 patients with CKD, uric acid superior to 72 milligram was associated with renal arterial wall thickening and yellinosis consistent with renal arteriolopathy. Let's get back to the meta-analysis that I've shown in the previous slide. And here it shows that uric acid level in the serum is tightly linked to the onset of CKD in all ethnic groups, in all genders, males or females, and no matter if the patient is diabetic or not. So whenever there is hyperuricemia, it's linked to the new onset of CKD. But what about the progression? In patients who already have CKD, does hyperuricemia worsen the kidney impairment? Well, yes, according to this Japanese study. The slightest, in patients who do have mild or moderate CKD, the slightest elevation in uric acid levels will lead to the worsening of kidney impairments. And hyperuricemia kidney damage is reported in several other conditions. In type 1 diabetes mellitus, hyperuricemia does predict the development of CKD in several trials. In AKI, having a plasma urate that is superior to 50, only 50 milligram per liter, is independently associated with the risk of hospitalization. What about IgA nephropathy? Well, hyperuricemia is shown to correlate with renal damage and progression of the disease. Now that we know all this, what should we do? Of course, the logical answer would be to treat our patients, as uric acid is recognized as a risk factor of CKD. And there is new data regarding the efficacy of urate lowering drugs and novel promising drugs that are in different phases of research. But then the question, does lowering uric acid can abrogate or partially reverse the oxidative stress in our patients. And what is the evidence of all that? So in order to lower uric acid in our patients, we mainly have three targets. The first target is to inhibit the enzyme, the special enzyme, the xanthine oxidase, and this way, uric acid production decreases. The second way to decrease uric acid is to supplement the patient with an exogenous uricase that reduce uric acid by catalyzing uric acid oxidation to allantoin. And the third category of drugs is going to be inhibiting the key transporters in the kidney, to inhibit the URAT1 as a main key transporter in tubular epithelium. And this way, to lower uric acid reabsorption and serum level. These are the uricosurics. So let's see briefly the first category of drugs that reduce the generation of uric acid by blocking the xanthine oxidase. The first is the allopurinol that all of us know and not very comfortable with because, and we're right, because it has, the main risk with it is a life-threatening hypersensitive syndrome that leads to mortality in 25% of the cases. And the fact of having kidney impairment is it in itself a risk factor of hypersensitivity, so adjustment of the dose should be considered in the patients. The second drug, febuxostat, is a strong selective inhibitor of xanthine oxidase, even stronger than the previous one, and it has no indication in asymptomatic hyperuricemia. So this drug is well tolerated in moderate to severe kidney dysfunction. There's no need to adjust the dosage. But in the recent years, there are some reports about the hypersensitivity of this drug too. Topiroxostat is the last drug in this first category of drugs that do inhibit the xanthine oxidase. This drug was approved in Japan exclusively in 2013, and it is unaffected by the kidney condition. And it's also, according to some authors, has a free radical scavenging activity, which can make it renoprotective and beneficial, especially with patients with proteinuria. The second category of drug is the uricase, the drugs that increase the removal of uric acid in the urine by adding an exogenous urate oxidase. It reduces the uric acid energetically and by catalyzing the oxidation of urate to the soluble allantoin. There are two main drugs mainly used in cancer patients to prevent or to treat hyperuricemia, the rasburicase and pegloticase. The last category that inhibits the reabsorption of uric acid by acting on the key transporter is the uricosurics. There's the probenecid, which is a very old drug. It has insufficient efficiency and is contraindicated in CKD patients who do have a GFR inferior to 50 milliliter per minute. The second drug is the benzbromarone. This is safe in moderate to severe CKD patients, but unfortunately, it has been withdrawn from markets in some countries due to hepatic toxicity. And last but not least, the lesinurad. This is an oral URAT1 inhibitor, but its efficacy is, to be efficient, it needs to be added to or combined with a xanthine oxidase inhibitor, because when administered alone, not only it is not efficient enough, but it can boost acute kidney injury, which is not very interesting for us nephrologists. Of course, when we speak about managing hyperuricemia, we should keep in mind the lifestyle changes that we should implement, the diets rich in antioxidants that we should advise our patients in order to reduce the oxidation. like vitamin C that is present in fruits and vegetables, vitamin E, both of them are significant uricosurics. The polyphenols that are involved in the xanthine oxidase activity that are present in apples, bergamots, and other fruits, and the flavonoids that can be found in vegetables, fruits, tea, grains, and wine involved in xanthine oxidase activity. Well, as we know, it's obvious that when a patient presents with gut crisis or does have a uric acid recurrent kidney stone, there is no problem with implementing a treatment. But when there is asymptomatic hyperuricemia, this is not obvious. Okay, that's fine. So does uric acid lowering improve renal function? According to some RCTs and animal experiments, yes, there is a positive link between lowering uric acid and improving the kidney function. But other RCTs, and there are several RCTs who haven't shown this positive relationship. There is this recent encouraging meta-analysis that has shown a positive link between lowering uric acid and improving the kidney function. But uncertainty remains, as there are some critics for this meta-analysis. Most of the studies that are included in it are of low quality with plenty of biases. To close this debate, there is this meta-analysis from the Cochrane database of systematic reviews that suggests that currently there is insufficient evidence to recommend the widespread use of uric acid lowering therapy to prevent or slow down the progression of chronic kidney disease in asymptomatic hyperuricemia. Of course, I have further research perspective. But to conclude, I would say that we nephrologists should be aware of the relationship between uric acid and CKD. Master the urate lowering treatments in CKD, the dose adjustments and contraindications. And according to the existing evidence, there is insufficient evidence to recommend the widespread use of these drugs to prevent or slow down the progression of the disease. And the treatment of hyperuricemia, of asymptomatic hyperuricemia, is not recommended according to this data. Of course, we need larger RCTs in order to answer this question accurately. Thank you.